Okay, I think we should make a start. People will continue to wander in from all over the world. Hello, everyone. My name is John Reed, and I am chair of the International Institute for Psychiatric Drug Withdrawal. Now, before I formally welcome you all and kick the conference off, I'd like to invite you all to take a minute to reflect in your own way on the awful events happening in Israel and Gaza, and not forgetting Ukraine. And it's moments like this I'm a bit envious of people who are religious, because you might be able to send a prayer. The rest of us who aren't will find our own way to just reflect for a minute on what's going on. It will just feel strange to start without acknowledging that. So let's take a minute. Thank you. Okay, thank you for that. Right, so welcome. We have people joining from, latest count, 22 countries. Always a special nod to whoever's come from New Zealand, where I was for 20 years. Well done for getting up at whatever time it is there. You win the prize for being the furthest away. But we also have people from Japan, Barbados, Brazil, and as I said, 22 countries. So on behalf of the IIPDW board, welcome to you all. The board consists of Olga, Marnie, Ruth, Joseph, Stevie, and Adele, and you can be meeting most of those during the course of the next 2 days, as they'll be introducing different sessions throughout the day. The conference is spread over 2 days, today and tomorrow. I've got a little bit of housekeeping to do with you, so bear with me. Each talk will last an hour, and there'll be a 15-minute break in between, and all but one of the talks will, which is a video, will have time for discussion, about 15 minutes at the end, built into the hour. The conference is being recorded, and will be emailed a link to the recording shortly after the conference. There's a question in the chat just now about that, so the answer is yes. But we'd like you not to share that link with anyone else, if you don't mind. That's just for you as an attendee. The purpose of the conference is to provide general information about psychiatric drug withdrawal, and our aim is for you to learn more about the subject and to be able to have better informed discussions with everybody that you relate to around this, whether that's your family or friends or your prescribing doctor. But we are not, however, giving specific personal medical advice. So we can't answer questions. It wouldn't be appropriate for us to answer specific questions about how to manage your own individual withdrawal journeys, but we can speak more broadly to the theme of your question. So please do ask about whatever matters to you. And the way to ask questions is in the Q&A box, not chat. Chat is for general discussion, but if you want the chair of a session to put a question to the speakers, please put that in the Q&A box. You can submit them anonymously if you like, and you can also upvote other people's questions. If you see a question there that you like, you can vote for it. You won't be able to save the chat because we want people to feel comfortable to share their views and experiences, but any links shared in the chat will be collected and emailed to attendees after the conference. You can use emojis to react to the speakers. You'll find this option at the bottom of your screen. This is a good way to interact because, of course, the speakers can't see you all, so it's a nice way for them to know how you're finding their talk. Presumably, it's a nice emoji. Otherwise, tell somebody else. No. Also, at the bottom of your screen, you'll see a button called CC. That turns on the automated closed captions. which are not always 100% accurate, but they might be useful for some people. At the end of the second day, tomorrow, there will be a separate Zoom meeting for you all to connect, those of you who'd like to. That will be a Saturday evening here in UK, but some of you might want to get off and do other things by then. But so there's an opportunity for you all to engage with one another for 3/4 of an hour. There's a separate Zoom meeting after the end of events tomorrow evening. The Zoom link for that meeting will be put up in chat, as will the hashtag to post updates about the conference. If you do have any other questions other than to the speakers, you can direct message Lucy on IIPDW admin, or email her on admin@iipdw.org. Lucy's with us the whole way. She's organised the whole event, so thanks to Lucy. I'm sure we'll be having many thanks to Lucy throughout the 2 days, but I'm going to get in first. These sorts of things can't happen without her. Finally, when you leave the conference, you'll be taken to a short anonymous survey where you can share feedback, and we'd invite you to do that if you would. Okay, so I'm going to do one last thing before I invite our first two speakers. On a very positive note, 10 days ago now, on the 7th, yes, just over 10 days ago, the United Nations and World Health Organization put out a quite groundbreaking joint report on the way forward for mental health services and the need for a human rights approach, a social approach, rather than a rigidly biomedical approach. And they had many, many recommendations. It's 180 pages, so don't worry, I'm not going to read you the whole thing, but I am going to read you the following. Countries should adopt a higher standard for the free and informed consent to psychotropic drugs, given their potential risks of harm. Legislation can require medical staff to inform service users about their right to discontinue treatment and to receive support in this. Support should be provided to help people safely withdraw from treatment with psychiatric drugs. So sometimes those of us working away in this field are positioned as a bit radical or a bit extreme or whatever, but we are actually just simply supporters of the World Health Organization and the United Nations. So thought I'd kick us off with that. So it's my great pleasure to introduce Tony and Anne. Dr. Anne Guy is talking today from her position as a member of the Secretariat for the All-Party Parliamentary Group for Prescribed Drug Dependence, and as one of the founder members of the Lived and Professional Experience Advisory Panel for Prescribed Drug Dependence, also known as LEAP, as well as an associate member of the Institute. Professor Tony Avery is Professor of Primary Healthcare at Nottingham University. He is in the UK, our National Clinical Director for Prescribing. His research focuses, amongst many other things, on patient safety in primary care, He also, equally importantly, actually works as a GP. So welcome, Tony and Anne. They're going to be talking about the future of deprescribing services in the UK, and in particular highlight how they're working together to ensure patients' lived experiences are fed into service design. Over to you, Anne and Tony.
Great, thank you very much. So I'm going to start and I'll just share my screens. So just give me a second and I'll just put that into slideshow view. Just bear with me. There we go. Yeah, so delighted to be speaking to you. And yeah, so Anne and I are going to be doing a double act. I'm going to be talking about sort of strategies we've got within England, within the National Health Service around deprescribing. I'll be talking generally to begin with about what we are doing, and then honing in a bit more on psychiatric drugs and also dependence for other dependence forming medicines, and then giving some examples. I mean, what I'd like to say is that we've still got some way to go. There may be other countries that are more advanced than us, but certainly in terms of the the strategies that we've got within the NHS in England, so the overarching body which is responsible for the NHS, called NHS England, then we're very, very much focused on trying to promote safe deprescribing services, including sort of safe deprescribing for drugs used in mental health conditions. Overprescribing is the use of a medicine where there's a better non-medicine alternative, or the use is inappropriate for that person's circumstances and wishes. And like with many countries around the world, then prescribing is increasing. That doesn't necessarily mean that the prescribing is wrong, but we know that there is a certain amount of overprescribing. So over a 20-year period, from about 1996 to 2016, there was a doubling in the number of prescriptions dispensed to people in seeing their GPs and others in primary care. And we know that there's been a considerable rise, for example, in antidepressants and other drugs used for mental health conditions. And there's also waste associated with that, and the associated impact on the environment. So why does it happen? We had something called the National Overprescribing Review, which I'll mention again on the next slide, and found it is a serious problem in health systems around the world. And there were both systemic and cultural causes for those. I won't go into all of them in detail, but basically on the systemic point of view, we have single condition guidelines. The guidelines are based on evidence which is usually done in relatively healthy populations who don't necessarily have any other things wrong with them, and therefore it can be difficult applying those to other people we see. But that is the evidence base, and so we tend to apply it and tend to apply the guidelines. And I think one of the real thing that strikes me is the lack of evidence on deprescribing. So, you know, recent systematic review from Mark Horowitz on withdrawal reactions associated with antidepressants. I was just astounded how little information there was, but just how little information there was, and very, very few trials. So things are just skewed towards prescribing and not considering what to do in terms of trying to help people come off their prescriptions. So I won't say any more on that side because of time. Culturally, then, the biomedical model favours medicines over alternatives. Despite our best efforts to promote it, there's inadequate shared decision making, and I think the point that John made at the beginning was really, really important in terms of always having a higher bar in terms of the importance of informed consent when people start on psychiatric medicines. The patients could be struggle to be heard, but they're also reluctant to challenge, and also there needs to be greater transparency of pharmaceutical sponsorship. So as a result, then, in September 2021, there's a government-backed report in the UK published the National Overprescribing Review, and there are 20 different recommendations in that, and I'm not going to go through all of those, but it's one of my main roles within my National Clinical Director role is to provide the clinical leadership for pushing forward those recommendations. So what I'm going to be talking about now, I'm going to just sort of talk on some of the strategies that are more relevant to deprescribing and particularly for the psychiatric medicines, although, as I say, I've covered some others. So one of the things we were excited about was the publication of a report we produced in March 2023. It's got a long title. It's called Optimising Personalised Care, so personalised care being important here, for adults prescribed medicines associated with dependence or withdrawal symptoms. So the medicines associated with dependence, the benzodiazepines, Z-drugs, gabapentinoids, opioids for chronic non-cancer pain, and in terms of withdrawal symptoms, of course, all of those can cause problems with withdrawal symptoms, but antidepressants also could cause problems with withdrawal symptoms. and to be offering non-pharmacological alternatives. So you've got 5 different actions, and I'll be talking about those in a little bit more detail on the forthcoming slide, and a number of case studies, some of them quite inspiring in terms of to encourage people to be thinking about how they deal with these things in their areas. Now, just use a little bit on terminology. We have something called integrated care boards. This is a relatively new thing in the UK, but they've got a very positive in terms of the concept behind it. It's the idea of trying to really literally in a geographical area, covering 1 to 2 million people. You've actually got an organisation that is responsible for the whole of care, health and care, with links to government organisations and charities, etc. So it can be taking that overview rather than being siloed in just looking at what a hospital might do or what a general practice might do. So they're a positive initiative, and it's those organisations that we principally develop this advice for. So firstly, what we're calling on those organisations to do is to embed person-centred care in their specifications or development plans, and provide opportunities for health professionals to practice personalised care through, for example, dedicated clinics or using structured medication reviews, which I'll mention in a moment. And then also really wanting to promote alternatives to medicine. So making sure that there are alternative interventions and services where appropriate, so that when a prescription is first considered, it's a genuine option. And I'd say there's been a real change over the last 10 years or so for myself as a GP, in the sense that it is a genuine choice to have someone with depression, for example. Then we do have quick enough access to talking therapies that is a genuine option, whereas 10 years ago it was a real problem, because if they're going to be waiting for 12 weeks to see someone about talking therapies, and they've got quite serious problems or significant problems, you could see that it's much more easy to prescribe in those circumstances. So one of the things that we've particularly promoted, and this is something that can help in relation to deprescribing, are what are called structured medication reviews. So as a GP, you would be expecting to be reviewing a person's medicines at least once a year and checking they're appropriate, but they're often relatively quick, just quickly checking through and making sure everything's okay. They're not always necessarily involving a patient, where structured medication reviews really are about having more time, typically half an hour, typically done by a pharmacist, and importantly having the patient or the person as the center of that, so that they can come with their own agenda and things that they wish to talk about, and focusing on what matters to them, and what they want to do in their medicine. So it provides more time for example, the pharmacist to go through the medicines, check that they're working for people, check how people feel about being on them, check if they want to change them at all, which may include with withdrawal, and then coming up with a plan. And evidence shows that people with long-term conditions using multiple medications can have better clinical and personal outcomes following these. So it's something that is it's an important initiative that we've been promoting with extra staff and training, and putting it into contracts with primary care. And so I won't go into this in lots of detail, but there's lots of guidance around for really adhering to the sort of principles that I'd mentioned there, and the 7 steps to appropriate polypharmacy can be applied to people on a relatively small number of medicines, but really checking through whether they are on the right medicines, if they need to be on those medicines, are the medicines working, are there harms that might need to stop them, and making sure that it's a agreed and shared medication plan. And we're doing a lot in terms of promoting that and supporting colleagues in delivering it. Also, specifically in relation to depression, we have a new service whereby community pharmacists will be, as well as GPs, will be following up patients newly started on antidepressants in terms of picking up any potential problems and providing support. So deprescribing is one of those things that may occur as a result of a structured medication review or an ordinary medication review. And we've done quite a bit, quite a bit in relation to deprescribing of antidepressants. So we have an organisation which you've probably heard of called NICE in the UK, which provides evidence-based guidelines, and they're very helpful to us, particularly as GPs. And they have actually got guidance in relation to people on dependence-forming medicines and in terms of deprescribing. And we've with Anne as well, we've sort of picked up one or two issues in relation to that, and actually managed to get the guidance sort of updated so that there's more helpful information in there, including patient resource from the Royal College of Psychiatrists on stopping antidepressant, and also managed to revise or get a bit wording revised on timing of medication reviews. But we recognise that there is further research still needed on practical ways to implement hyperbolic tapering, and there's a link to a paper on this there. So just give you one or two case studies. So these are ones where we produced the guidance, we produced our framework, but in producing it, there were some examples from initiatives that had happened before that. So I'm just going to give one or two examples. So this is a service on benzodiazepine and opioid withdrawal in Camden and Islington, which is in London. That operated 20 different surgeries and provided advice and information about medicines and deprescribing, gradual reduction through tapering, psychosocial support, cognitive behavioral therapy for insomnia, and then liaising with pain clinics. And of the patients who started their dose reduction, about half of them managed to complete this, and of these 53 were completely deprescribed, and 53 managed to reduce their medicines doses. So in terms of a little bit more on alternatives to medicine, which I've already mentioned, then an example of a great service in Gloucestershire was looking at improving services for people with chronic pain, and amongst a whole range of things, including social prescribing, they have got a scheme for including for promoting greater movement for people to do sort of exercise and activities in the community, and that leading to reductions in pain and improving function and improving mental health as well. And then another really important initiative that a lot of resource has gone into is the creation of social prescribing link workers and health and wellbeing coaches, or at least NHS investment in that, because there has been there's been this facilities for a while, but we're talking about thousands and thousands of people being trained up to be health and wellbeing coach and social prescribing link workers. And again, going back to what I was just saying earlier, it's something that is therefore a genuine choice for us as GPs, that if you feel that someone would really benefit from someone having a more detailed discussion about what's important to them, what matters to them, and then having the option that they could then be perhaps referred on to another either service or something else. It might be a gardening group or a music group or a dance group or art, whatever there is in the local area that might just help people, then that's something that's been strongly promoted. So I think that's been a real positive initiative. And then also, as part of our framework, what we're particularly encouraging these integrated care boards to do is to take a system level what we call task and finish groups. So you get everyone relevant together and look at what is available at the moment, particularly in relation to the types of medicines that I was saying, and then look to see whether new services need to be commissioned to help people wishing to reduce or stop medicines, and also really encouraging a whole system approach to that. Primary care, secondary care, local authorities, third sector bodies such as charities. And another example from Gloucestershire was how this was done. They did a brilliant job in terms of co-designing this, really talking to clinicians, to people with lived experiences, to work out what are the best ways of helping people, and provided a number of different services to help with that. And then some particular things in terms of addressing inappropriate antidepressant prescribing. So we're keen to mitigate the increase in inappropriate antidepressant prescribing to avoid harmful and distressing symptoms, including those associated with discontinuation, and got actions around establishing locally commissioned specialist services, although it's taking some time to get those going, and the Royal College of Psychiatrists resources to support patients as well. So we want to see outcomes in line with our NICE guidance on treatment and management, and implementation of these integrated care board services to support those suffering from severe problems associated with antidepressant withdrawal. And we've got a number of resources available, which, I mean, they are freely available. So click on those links, or most of those links, and you'll get to relevant information. But you know, those being specifically planned for colleagues working in the NHS in England. So just another example of a deprescribing case study, another one from our report, and this was an area called Rotherham, which is in South Yorkshire, which is in the north of England, and it was a pilot program to support deprescribing of long-term antidepressants in primary care, and they had a standalone so-called one-stop review clinic was set up to review and prescribe titration regimes for patients using their own GP records. And it was based upon patients who'd volunteered to be part of it, which is perhaps why the pilot was so successful. But they successfully managed to stop or reduce antidepressants in over 600 patients, with only a small number reporting adverse effects. I'm actually going to be speaking to the person who's behind this in a week or so, because it seems a very, very small proportion that had problems. But you know, I'll find out more about that soon. So in terms of what's happening in terms of implementation of the framework, it's 8 months post framework for action. We know that some integrated care points have appointed specific roles that focus on addressing problematic polypharmacy, or focus on prescribed medicines that cause dependence and withdrawal. And there's good examples of safe deprescribing services in our framework for action. But we definitely recommend there's more here to do to encourage our integrated care boards to fully implement our framework for action, and to really help people more who are those wishing to reduce or stop medicines associated with dependence and withdrawal symptoms. I'll be really interested in discussions today to get ideas from colleagues around the world. And then finally, in terms of our work in terms of the framework as population health management. So we're in a very good position in terms of the NHS in having this single health service, in having very good data in relation to in terms of people and the problems they have, and where the problems are greatest. So we have that opportunity to be able to say, for one of these integrated care board levels, we see where the biggest problems are, where the biggest need is, so that it's possible to direct your services accordingly. So I've got any questions here, but we'll take questions afterwards, I think. So I will stop sharing, and then we can go on to Anne.
Thank you very much, Tony. I'm hoping that actually some of my presentation will address some of the questions that have come up in the Q&A whilst Tony's been speaking, because I think what everybody can recognise is the gap between the policy and the intention and what's actually available on the ground. And one of the big things that Tony and his team, it's great that they are willing to work with this in the way that they are working, is that they are listening to information that we're providing about patients' experiences. And that's what I just want to give you a bit of flavour of some of the detail on that. So let me just share my PowerPoint. Because the devil is in the detail when it comes to this. And we've heard some really excellent ideas and concepts and frameworks and policies that Tony's been talking about. Does it all actually add up? Where are the gaps? What are the barriers? What are the risks to all of this? So myself, Mark Horowitz, which I know who many of you will know about who Mark is, sort of leading researcher when it comes to hyperbolic tapering, and also somebody with lived experience, and Luke Montague. So we're coming at this, we all do some work as part of the Secretariat for the All-Party Parliamentary Group for Prescribed Drug Dependence. But we're also all founder members of the Lived and Professional Experience Advisory Panel, or LEAP, which I'll just call it LEAP from here on in. So it's great that we're working with Tony, we're working with a chap called Peter Pratt, who's the Specialty Advisor for Mental Health Pharmacy, and also now Justine Scanlon, who is head of the Specialist Pharmacy Service for the NHS. I appreciate this is very England-centric, very UK-centric, but actually, you know, coming back to Tony's point about are other countries further ahead than the UK? Actually, probably not, is what I've heard. I think we're probably, if not, you know, one of the leaders, you know, the leader in terms of action, but it's yet to translate on the ground, perhaps. So we're all kind of working collaboratively, and this is a huge opportunity for us to feed in information about the reality on the ground. So we've got all of these different initiatives, which Tony's talked about, a number of those. So what are some of the gaps here? So the NICE guideline on safe deprescribing doesn't actually tell doctors how to prescribe, doesn't actually tell them how to taper. So this is an important and a hugely important aspect, that we try and get information to doctors on how to do this safely. And it's also true for the structured medication review programme that the guidance currently doesn't actually mention withdrawal. So these are the kinds of things that we're bringing to Tony and Peter and Justine's attention to try and influence corrections, amendments to these kind of policies. So first of all, getting access to clear information about how to taper, and Tony mentioned simple things like getting the link to the Stopping Antidepressants patient information resource from the Royal College of Psychiatrists, getting that into these documents, that's a step because it actually gives GPs a chance to find this information. We know that without access to resources, tapering is difficult. And I saw a number of you in the questions asking about tapering strips and how hard they are to get hold of. This is also can be true for liquids. And this is something very specifically that the group of us are working on to identify what the issues are. And I'll touch briefly on that in a second. And Tony also mentioned the importance of data collection, because without data collection, there's no visibility of the problem. And up until incredibly recently, there have been no codes inside systems for this to be recorded. So it's not been a visible problem. So how do prescribers get reliable information? And when we're talking reliable, I'm really talking about information about hyperbolic tapering, because we know it's not a safe route, because we know there's no guaranteed safe way of tapering, but it's the safest route that collectively the wisdom and experience of the lived experience community has identified. What we're trying to organise is for there to be, and this has been agreed in principle, that there is one place inside NHS systems, the Specialist Pharmacy Service website, where all of these other places will point to, and that this site will contain information about antidepressant withdrawal. There will be some video clips and talking heads about people talking about their experience of antidepressant withdrawal. There will be some information and links to how to devise a tapering program and how to access the relevant resources. So this is a huge step forward, and it's something we're currently actively working on. So it's not in place yet, but we hope very much to have a lot of this information on the SPS website in the early next year. So, okay, resources, liquids and tapering strips. So we know this is a problem. We know that some GPs perceive them as being expensive, or they don't know how to prescribe tapering strips. So Tony and I and the group, we've agreed we are going to map out the current process that GPs have to follow, and we are going to see how we can improve that process. How can we streamline it? How can we make it clearer how GPs can actually prescribe these things? And also give them explicit permission to do so, because sometimes there is a barrier that because there's the perception of expense that they think they can't do that. And actually, Tony's been very clear that there is no barrier in terms of recommending these things from an expense point of view. Tony, I'm sure will correct me if I've overstated that, but that's what I'm remembering.
Yeah, that's right. I mean, there's a limit, you know, sort of costing £1,000, but basically, if it's the standard liquid preparations that say cost £30 a month rather than £3 a month, then
yes,
yeah, I think you'd be supported as a prescriber for doing that if you're trying to help someone come off their medicines.
Yeah. And one other important, and it's this tiny stuff in the detail that as a result of the conversations that we all had as a group, Mark, supported by Tony and Peter, went off and requested a code to be added to the software for protracted antidepressant withdrawal syndrome disorder. So this can actually now be captured on systems and the problem start to become more visible. So a copy of my presentation will be available, so you can actually, if you need to, take this information along to your GP and ask for it to be put onto your record. And this is part of ensuring continuity of care if you're going through withdrawal. So Tony also mentioned structured medication reviews, and on one of his slides he talks about the resources to support patients going through it. So we at LEAP, I've put out a call to members of the lived and professional experience advisory panel for people to go through this information so that we can go back to Tony and say, yeah, it's great, but can we add this, this and this, or this isn't mentioned. So that's, again, it's a live thing that we are doing, and it's an opportunity to feed into the system and actually make sure that it's as helpful as it can possibly be. Tony talked about systemic and cultural problems that have been identified from the system's point of view, from the NHS point of view. And it's interesting how far they map onto what patients experience. So there are 8 main failures that from analysing patients' experience of the system that we need to try and make sure we're addressing. So Tony mentioned this: lack of alternative interventions to drugs. When a drug is prescribed, the lack of information giving about dependence and withdrawal risks, so the lack of informed consent. That on a review, if somebody is struggling with a drug, that they're continued or a dose increased or somebody's switched rather than considering just stopping the drug. That if somebody wants to try and come off, that at the moment, there's really very little informed support from GPs. I think Tony, we know, is one of the rare GPs who knows a lot about this. When there are withdrawal symptoms, they're often not recognised. And sometimes those symptoms are located with the person and not the drug. And so they get sent for all sorts of tests which are unnecessary. So this is a hidden cost in the system of withdrawal. We know that there is currently very, very little dedicated support for withdrawal from prescribed drugs. We know we now have the framework. It's not yet in place. It's very little take up so far. And I think this is a common issue across the NHS, and you can see it in all sorts of different issues and examples with different types of treatment. There's very, very little effective feedback route for patients' voice inside the system. Now, as Tony says, we're looking for a whole systems approach to dealing with this stuff. And the NHS is currently very good at getting better at doing this for opioids. So there are 11 integrated care boards in the UK who have adopted a whole systems approach to high-risk opioid prescribing. And what we're hoping is to persuade an ICB or two to start doing this for other classes of drugs, so that we can address the entire system and knit this all together end to end, because we've got so many bits of the jigsaw puzzle. So collectively, we're trying to ensure that we've got access to information, we've got fit for purpose processes, we've got access to resources. So the moment that we get an ICB who says, oh yes, what can we do? All of the building blocks are in place to actually enable this to happen. So there will be a gap between what we're talking about and what you're experiencing on the ground at the moment. But hopefully this gives some sense of there is at least the possibility of it coming. Just a sort of final slide in terms of what any things that are going, other things that are going on. We're still interested in finding someone, finding a way of getting funding for a national helpline to help support people going through withdrawal. Clearly, the aim is that people are not pushed into withdrawal in the first place. They go through a safety prescribing process. Until that's in place, there's an awful lot of people out there suffering who need access to some kind of support. We're actively looking for this NHS organisation who will pilot the whole system approach. And if you're in the UK, you could write to your local ICB or NHS organisation to say, how are you implementing this framework? You can also register on the LEAP website to say, I'd be interested to work with my local NHS organisation when they get round to putting together a project team. As somebody with lived experience, I'd be happy to be consulted. So that's my whistle-stop tour through some of the detail of how we are working collaboratively. So that gives us 15 minutes, hopefully, to answer some of the questions.
Thank you, Anne and Tony. So I'm looking through the questions you put in, questions and answers, and Anne's already covered a couple. There's one that Tony said he specifically would like to answer live, so we'll start with that one. And this is from Heather, who says, who asks, are there any laws in regards to this deprescribing? So any laws, and are the NICE guidelines, can they be ignored? And do they apply to everyone regardless of situation, including, for instance, mental health status? So there's 3 questions in one there, Tony, but you said you'd like to address that.
Yeah. Sorry if I missed the last bit, so you can pick me up if I. So having NICE, having this organisation called NICE that produces the guideline is very, very helpful for us, particularly as GPs. It does mean that as a GP, I can be practicing the best quality of medicine. I'm not just relying upon my own memory. I'm not just relying upon some random Google search to work out what to do in a situation. And so that is very helpful. And I think GPs increasingly make quite a bit of use of it. But that, it is called guidelines, so it's not, they could say guidelines, not tram lines. So it is there for guidance, which means that it's not essential, it's not mandatory that you follow these things. I think one of the things that I note is that it's where NICE comes up with guidance for non-pharmacological therapies and saying this should be available, that should be available. That's the thing that's frustrating, because it's then down to the local health system to decide whether or not it's going to put in place that service or not, and often they're under cost pressures, and so that's where we sometimes have this frustrating disconnect really between what's in the guidance and actually what's available, and that's where I suppose the people like myself and Anne and her colleagues are doing our best to be raising the profile of these things to try and encourage, in the whole different ways in which we can, for the relevant services to be taken up. Now, I may not have answered everything in that. There was something else, John, about.
Do they apply to everyone, for instance, regardless of mental health status, where
yes,
culturally medicated?
And it may not be the on the ground reality, but there's very, very much having it's dualism anyway to do separating sort of mind and body, but yeah, that people with mental health problems have got the priority that everyone else has for high quality health services.
And did you want to chip in on that at all, or should we move on?
No, I'm happy to move on.
So I'll put a couple of questions to you at the same time, and that way we might get through more. So here's an easy one and a hard one, I think. So what from Ruth, what other alternatives can be prescribed in terms of social prescribing? And here's the hard one from Clive, who points out that doctors are notoriously difficult to persuade to change lifelong habits. What advice or tricks or whatever have either of you learnt about how to get through to GPs and psychiatrists to actually change their behaviour? So easy and hard, I think.
What was the trouble is you answered two, and I'm a bear of little brain, John. What was the first one again?
Okay, we'll go. All right, sorry. Just some other. This is quickly then. So just throw out a few other alternatives.
Oh right, okay. Sorry, you're right. Yes. So I think it depends when we're talking. So there are two stages here. I think one is before drugs are even prescribed. What alternatives might be possible, and of course, it depends where you live in the country as to what's available through social prescribing for non-medical interventions. And also, we mustn't forget the value of watch and wait, because so many times mild to moderate difficulties will disappear naturally because they're circumstantial. It might be a loss and it takes time to heal from that. So that they will very naturally resolve, often within a year anyway. Now, I know a year sounds a long time when you're going through it, but in terms of being caught on medications and potentially how long that might last, sometimes when watch and wait is the right thing to do rather than prescribe something. So that's at the first point of prescription. But then I think when it comes to deprescribing, and to help somebody get through withdrawal, I think there's another role for social prescribing at that point, when if somebody's trying to withdraw and step down their dosage, there may well be other coping mechanisms that might help actually get through withdrawal. I'm sorry, I'm not giving you specific examples, but there are lists of the kinds of things that people find helpful in withdrawal. And we know the kinds of things that psychological interventions and group activities and activities that emphasize human connection are all part of that.
Okay, let's see if Tony wants to add to that list before we jump to the harder question.
So I won't answer the list. I'm aware of time, so should I go on to the more more difficult, which I think sort of fits with some other things. It's about difficulty persuading doctors to change, or at least doctors to have that open approach. So what I'd start by saying, if we talk about GP, so first of all, in our training, and I'm pretty sure it'll be the same in most other countries apart from general practice, then it's certainly a training that is very, very good in terms of encouraging patient-centeredness, good communication skills and listening, etc. It then potentially hits the reality of practicing and where you're under tremendous pressure. So when I started, then we were sort of getting towards like one GP per 1,700 patients. In England, it's now like one per 2,300. So we have more patients that we're dealing with, and also the expectations on GPs, particularly in the UK, is massively increased. So the responsibilities that we take on are really quite tremendous. It's not just like people used to think, sort of GPs just do with just a simple, straightforward things. So I think that's the challenge, is that GPs are working under considerable time pressure, and therefore, paradoxically, it makes it easier for them to prescribe things and just go for what seem like simple solutions, which are not necessarily the most sensible solutions. In terms of actually handling that, I mean, of the various things that I might suggest, I think, going in with specific requests. So in other words, making it clear that this is, the one thing that you want to be talking about today, which might be, I want to talk about the potential of coming off my antidepressants, for example. Asking if the GP can't help, and I'd hope that they would feel that they could help with a specific request like that, then asking whether there's anyone else who could help them, if they've got a pharmacist, because most practices do have links to a pharmacist, or indeed whether there are any local services, including psychiatric services. So there'd be just some pointers.
I can just add to that as well. I'm just seeing some of the things that are coming through in the chat around that. And we hope very much through the information we're going to get on the specialist pharmacy services website, really explicit permission for GPs to prescribe liquids, to go through the tapering strips prescription process. This is, hopefully once we've improved the process so it's easier to use. And also the specialist pharmacy service is also responsible for giving guidance on kind of off-label or how to dilute liquids, how to manage smaller doses in general. They have a whole quality team set up to answer those kind of questions from anybody clinical. So they really, hopefully, will be able to directly address any query that a GP has. And of course, the more that we put on there, the more that we inform the patient community, the patients can tell their GPs, look at this website, and it's a trusted, credible resource inside the NHS, that hopefully we get this loop going where more and more GPs are understanding that this is part of their role to know more about and to inform themselves, and that the resources are available to do so. So I think giving explicit permission to GPs to do this and is part of the picture.
Yeah.
Thank you both. So next question, this is from Cheryl. How much of what you're talking about today, or indeed she's asking about the whole event, applies to antipsychotics, which is, and this is a question close to my heart. I should just quickly say that antipsychotics is definitely part of the remit of the International Institute for Psychiatric Drug Withdrawal. But Tony and Anne, how much of what you've been saying today?
Shall I pick that up first?
Please.
I would say very much so, but what I would say, and I was speaking to the Conference of Mental Health Pharmacists a couple of weeks ago about this, is that one of the real challenges for GPs is having people who have been in psychiatric services. They then get better enough that psychiatric services no longer feel they need to see them, but they actually come back to general practice on a whole host of medications. They're often on a couple of antidepressants and an antipsychotic. And these are people without a psychosis diagnosis. And GPs will not want to touch that because they just worry that something bad's going to happen. And so that's something I'd be pushing that group and others to be saying, if people are discharged from psychiatry, then there should be a plan. There should be a plan for us in terms of, ideally, they should be helped to deprescribe from these things in the first place before sending them back to us. But then, actually, yes, it would be okay if things are going okay to withdraw this over time, or if not, to actually be setting up services that can help with this. Because in my experience, people literally could be on these medicines for decades, and then it could take years to get them off. And the fact is, I think they don't need them anymore. So anyway, it's a long answer to yes, antipsychotics are part of it, but it's challenging certainly for GPs. And
just to highlight also that it's important that we think about the prevention end of how do we stop people being put on so many drugs in the first place. And one of the things that John and I are working on separately is thinking through, well, how might services be influenced to be less based on drugs in the first place, to be less reliant on pharmacological solutions, to be more community-based, to be more based on social connection, on crisis safe spaces, rather than the more chemical restraint that tends to happen in institutions. So there is that whole other movement of actually how should our mental health services look in the first place in terms of the kind of services that are being provided. But it is tricky. And I think my answer on the antipsychotics would be, they're not often explicitly mentioned. They weren't in the PHE review. They're not in this NICE guidance. Our hope is that we get all of these processes very clearly set up and all of this going for the bigger volume drugs, and then antipsychotics will naturally follow behind. But they are a harder ask politically. People are scared of the idea of people coming off their antipsychotics. There's the whole cultural, the social media messaging, social messaging around what does it mean to be psychotic and unmedicated? Somehow that means you're automatically, running down the high street with a knife in your hand. And it's just nonsense in terms of the cultural messaging that happens around psychosis. So there's a whole passel of very difficult stuff associated with antipsychotics that I think we're aware of as a reality.
I would just add, abusing my position as chair, I would just add that, yes, it is nonsense. There is no evidence that antipsychotics prevent people killing themselves or anybody else, but the mythology around that,
yes, it's very powerful.
So people ask it. Thank you for asking that question. I'm going to put one more question to you and then give you a chance to make some closing remarks. This is a sort of a statement and a question, but I think it captures how a lot of people feel about this. This is from Caroline. People are continually being harmed by ill-informed advice about how to safely come off their meds, as in typically being told you can come off over a few weeks, or just being told cold turkey. This causes immense harm. My question is, where is the accountability here? Shouldn't prescribers be held to account somehow for prescribed harm? Because at the moment, it just feels like you take these medications on trust, but if you have any issues, you're on your own. I know it's a difficult.
So shall I start? Shall I start? Yeah, I mean, you can go down the accountability route, or you could go down the route of trying to educate. I think we've got a problem with as been acknowledged already, with us as GPs not being well informed in terms of withdrawal, say from antidepressants, and how best to do it. So that's the route that I would want to be going down. You know what I mean? It's not. I don't think that prescribers are deliberately suggesting these what are inappropriate withdrawal regimes. They're doing it because they haven't got the knowledge. And I know it sounds awful for people to think, well, these are trained professionals and they haven't got the knowledge. But there are, if you look at the GP curriculum, just thousands and thousands and thousands of things you need to know about. So you don't know about everything as well as you should do. So I think it's something that's for people like myself and others to be trying to get the messages out there, and they're kind of fairly simple messages, really, so that actually people who are prescribing have full knowledge of that. They are appropriately counselling people at the start, and actually know how to help people come off them in an appropriate way.
And I'd just add to that two things. I think, backing up what Tony said, this is a systemic problem rather than an individual issue with GPs. This is to do with the training and the system. And also beware of adverse consequences of things, because I remember sitting in an APPG meeting once where a doctor was saying, be careful about, for example, if you monitored every GP in a practice to see how many antidepressants they were prescribing, you might well have some GPs that look like they're prescribing more than others. But actually, very often in GPs, you get some GPs who are more experienced they take on a little mini specialty within the practice in dealing with certain issues. And so their prescribing rates will look anomalous to everybody else's because they're actually doing more of that work within the practice. So it's actually very difficult to drive accountability without inadvertently creating another problem. And I think the systemic approach of improving education, awareness, and access to resources and easy processes is probably far likely to yield quicker results than if we get too much into a blame game. People end up being defensive and reluctant to be honest about what's going on.
Okay, I would add there is some accountability to a much higher level, in as much as increasingly drug companies are being ending up in court because of the misinformation that they give to GPs and psychiatrists. But that's a different
Yes,
level.
that's a good point.
Now, apologies to everybody if I didn't get your question in there. I should let Tony and Anne know that along with the questions, there's lots of comments about great talks, lots of information. Thank you so much. But I can give you each 1 minute to some closing remarks. So, Tony, would you like to go first?
Yeah, well, first of all, I'm just sorry to hear the experiences that so many people have had. And I suppose the challenge for people like myself and Anne, who are, as you could tell, are sort of firmly committed to trying to improve things, is actually to make that connect between, you know, what we're wanting to do quite clearly within the NHS, say what we're wanting to see, what NICE are wanting to see, and actually what happens on the ground when on the ground is in very difficult circumstances. So that's the challenge for us, and I think, you know, as much as we can all work together to try and make that happen, it's the things I'd be wanting to promote.
Yeah, I think I heard a phrase that really summarizes this, that we are in the process of trying to stitch together our meager resources. There is no additional funding for this framework. We know how much pressure the NHS is under generally. We need to be quietly influencing. We need to be talking to people. We need to build relationships with our local NHS. Just keep talking to people and trying to persuade them and point them to the sources of evidence on this. And that, at the end of the day, will win over. It won't be as fast as we would like. I think we can just all, I'm hopeful that perhaps after a change of government, perhaps we might see some different responses to funding, but who knows, and that's a long way away. But in the meantime, there is stuff that we can still be quietly getting along with in the background.
Thank you both for such a wonderful start to the conference, and thank you for all the work you're both doing, along with all your various colleagues and networks. There's a lot going on. We are very, very slowly moving in the right direction. So thank you for all of that.
Thank you for inviting us, John.
Yeah, thank you. Thanks for all the emojis that are coming through.
Yes.
Thanks for all the questions and all the thumbs up and everything. So let's take a 50-minute break now, and we will start again at 20 minutes past the hour, wherever you are. See you all soon.